So Professor Hillman, thank you so much for your really moving and I think very important opening session for our conference today. And I just wrote down a few things. So one of the things that kind of spoke to me was you said there's a myth that hospitals are a good place to die, and actually we're not very good at the dying process in acute hospils. Would you like to talk a bit about that?
You do 5 or 6 years of medical training in order to make people better, to cure them. And there's hardly any lectures or emphasis on how to conduct a really good dying process.
Absolutely.
Palliative care is taught, but that's really end stage and it's mainly cancer. But most of the people that die in hospital are older people, and they're not really palliative care as such because they're dying normally and naturally of old age.
Normal aging process.
And we don't look after that very well. We don't. First of all, we don't actually tell them that they're dying.
We don't talk about it,
which is a good start. And they're frightened. They're often sort of delirious. They get confused. They like to be at home, but they're continually dragged in and out of hospitals for the last 6 months of their life. And it's look, these are well-meaning people in hospitals. They're not bad people, but they're just not geared up or trained to look after dying, especially the elderly, very well.
Yeah. There were some staggering stats that you put up that even for me working in an acute hospital, I found really surprising. So in the last 12 months of people's lives, they have something like 8 hospital admissions, 2 ED presentations, and 60% to 70% chance of dying in hospital.
Yes.
What are we going to do about that?
Yes, and look, we're just beginning to look at not just whether they live to leave hospital, but we're looking at what happens afterwards. And that's pretty frightening data, because many of these people, for example, over the age of 85, most of them have died by 12 months. So we should be looking at 3, 6 months, 12 months mortality. Even more important, we should be looking at the quality of life. Absolutely. As older people are coming to the end of their life. Hospitals are not good for older people, basically. And because they've got comorbidities which are progressive and irreversible, hospitals really haven't got much of a role there anyway.
Not much to offer them.
So it's just a bad situation for everyone. Patients don't like it. Hospitals are overcrowded and they're not very good at treating older people at the end of life. So if we could do something about it, it would be win, basically.
For everyone. And how do you see our role as intensivists and anaesthetists working together to try and make things better for our patients?
Oh, look, I think that we're in a unique role. First of all, to talk to society about what really happens.
Yeah.
And we do that by making films, publishing books, giving talks to lay people, trying to increase the awareness of society to the fact that death is inevitable and you're not going to be cured when you go into a hospital. That's a start. But I think there's a great role for the anaesthetist, especially in the preoperative clinic, where they could curb the enthusiasm and optimism of the surgeon by also talking about, even without the surgery, they may not have too long to live.
Sure.
And what are their real wishes and choices? And in order to do that, you've got to give them proper information, not just about what chance they've got of living after the aneurysm's repaired or the heart surgery's done, but also about the pretty gloomy picture of what happens afterwards.
What they go through.
Yeah. And the fact they may not have too long to live anyway.
After that.
Yeah.
And so that takes a lot of time, doesn't it? And that's, I guess, trying to involve our medical administrators and management in, we need time to have those discussions, don't we?
Exactly. Look. The more work we're doing in this area, we sort of believe that this is a specialised area, and we've got 3 nurses.
Right.
And some of these conversations take an hour and a half. Many of them require a follow-up because the older person hasn't taken it all in.
Let's go home and process it with their family.
So this is a lot of time out of a specialist surgeon or specialist anaesthetist.
Yeah.
So we're sort of working on this as a new nursing
additional
role.
Specialised role as an adjunct to what we do and to help us. That's really interesting. Thank you so much for talking to me today, and really a privilege to meet you.
Thank you. Thanks a lot.